To me, residual MR means go back to surgery. So I'm not really sure what is the purpose of talking about this. But going over the literature and then after a couple of weeks of preparation, I realized that there's a lot of things that we can talk about when it comes to mitral repair and residual MR. As you can imagine, and if you listen to all the talks from yesterday and today, there are a number of causes for mitral regurgitation. Of course, the most common cause of rheumatic heart disease in Saudi Arabia, or the most common cause of mitral regurgitation in Saudi Arabia, is rheumatic heart disease. Degenerative disease or myxomatous mitral valve definitely is here, but definitely it's a distant second compared to rheumatic MR. Other causes of organic, MR include, some of the list that you are seeing in this slide. I would just mention endocarditis as always a reason for MR anyway. The concept of mitral regurgitation and mitral valve repair was introduced very early in the 1970s by Prof. Carpentier. And I do remember actually when I was actually a resident in the 80s, and I was lucky enough to work with Professor Duran, who headed our department in King Faisal Specialist Hospital in Riyadh, I believe in the 90s. I think it was the 90s, for 4 years or so. He was talking all the time about mitral valve repair and Duran ring, and we did a lot of repair at that time using his ring indeed. Anyway, just to have a look at this organic MR, look at the mitral valve on the right side of the panel, and you will see what rheumatic mitral valve indeed is basically a complete fibrosis of the mitral apparatus. And look at the mitral valve on the left side of the panel. And this will give you what a normal mitral valve looks like, and in the middle you will see what myxomatous or degenerative mitral valve is. The other causes for MR that we see quite often here is functional mitral regurgitation, and mainly because we have a high prevalence of cardiomyopathies, and particularly ischemic cardiomyopathies with secondary mitral regurgitation, and of course because of dilated cardiomyopathy. And these patients actually indeed have a high prevalence of mitral regurgitation, and as you heard Dr. Kharabsha yesterday, severe mitral regurgitation in the setting of functional mitral regurg still really constitute a major problem and not easy to answer in most cases. This is just an example of functional MR. The causes, of course, of severe MR in functional mitral valve disease, as you can see, reduced closing forces on the left, and that's what's causing that, and the increased tethering forces on the right. And I guess he went very nicely over it yesterday, so there is no point of going back to repeat it. The current therapeutic modalities for mitral regurgitation, varies from, of course, medical management in the early phases of the disease, which, normally, when we talk about mild or moderate disease without symptoms with normal ejection fraction, and I think that's acceptable, and based on guidelines, medical therapy and observation is all what you have to do. The problems arise actually when mitral regurg becomes so severe. Then actually the standard of care for mitral regurg is either you do surgical repair or replacement of that valve. You know, it strikes me actually to note that with all the talking about mitral regurgitation over, the past, 20 years of my experience as a cardiologist, to say the least, I did not realize that all our mitral regurg that we are tackling, whether it's rheumatic or is it related to myxomatous valve or even cardiomyopathy, which are not doing so much right now, indeed, that only 20% of patients who have severe mitral regurgitation actually end up having mitral valve repair or replacement, because the other 80% are very sick or very, old, or they have so many different medical conditions that make it completely impossible for them to go for surgical treatment. This means that there is a very large number of patients with severe MR who are symptomatic, probably or partly because of this MR, and were not able to intervene. And it is actually and that's really where less invasive technique for reducing mitral regurgitation or curing mitral regurgitation comes to mind. And here I'm talking about particularly the less invasive transcatheter mitral clip, which I think will help a large number of patients, which is much more than I thought, indeed. Of course, I mean, we cannot talk about mitral regurgitation without talking about echocardiography. And, the diagnostic test of tool, as we know over the years, is echo. Now we have much more advanced echo techniques. We have transthoracic echocardiography. We have transesophageal echocardiography, which give you more detailed look at all the anatomy and the problems of the valve, starting from the left atrium into the mitral annulus, leaflets, the chordae, even sometimes the papillary muscle. And definitely this has been a major help in patients who underwent mitral valve repair in particular. Things actually got even better. Not only TEE, that was 2D TEE, now 3D TEE has been introduced actually for actually at least 5 or 6 years in so many laboratories. I have to admit that till now we are not really applying, although we do have actually the 3D TEE probe, we are not doing it actually routinely on our mitral valve repair cases, and this is, I think, a major deficiency from our side, the echocardiologist side, which I think is going to be a major help to our surgeons to improve results when it comes to mitral valve repair in general. There is this parametric display of anatomy. I just want you to look at how, what type of display you are going to see using this actually, software, using 3D TEE, where you can see actually all the leaflet lines. You can see the anterior, and of course the anterior is towards the aortic valve. The posterior is, of course, in the opposite side. And look at how nice the cooptation line that you can see, and how how easy to to identify where is the problem, where is the cooptation deficit, or where is the rupture, or where is the prolapse. Looking at this parametric display of mitral valve. We have this quantitative parametric anatomy. It's even actually give you even more information. And I mean, just this cartoon on the left side, just for our junior actually staff, residents and fellows, just to go for the looking at the different when you talk about A1, A2, A3, P1, P2, P3, this is actually the in-face view of the mitral valve, and it's important to remember that the most lateral is the A1, the most medial is the P3, and of course in the opposite side. The most common actually segment for prolapse in myxomatous mitral valve, most frequently encountered, of course, is P2. Anyway, the point is that there is a lot that we can do as an echocardiographers to help really in this problem, but of course I think it's work in progress, but I know that I'm saying this just to make sure that we cannot put all the blames when it comes to results on our cardiac surgeons. There is a lot of work that we have to do ourselves as cardiologists to improve the outcome. Now, when we say mitral valve repair, and I have to apologize for all the cardiac surgeons for some of my ignorance about their surgical techniques. I didn't realize that they know that much actually about the valve. I mean, you can see the whole list of different techniques for mitral valve repair, and I left probably other 4 or 5 different techniques to repair the valve. What is really important here to remember is the technique that is used for the mitral valve repair is very important in the final result. And whenever the technique improves, whether it's annuloplasty size, whether it's the type of the ring size, or whether it's rigid, is it soft, is it semi-rigid, is it complete, incomplete, also the type of chordal transfer, what they do with the chords, what they do with the papillary muscles, all important in the final results of mitral valve repair. Now, successful mitral valve repair, I think it's by definition, when you say mitral valve repair, it means that you repair the mitral valve. And if you repair the mitral valve because the patient has mitral regurgitation, so you do expect mitral regurgitation repair to be successful, and when you don't have any more mitral regurgitation. When there is 0 mitral regurgitation, when the patient leaves the OR, then you have actually successful mitral regurgitation. Is it that easy? Is it that simple? Is it that straightforward? The answer is no, actually, and we'll talk about some of the reasons for it right now. We know that mitral valve has been graded from 0 to 4, or 0 to 4 plus in different actually centers, and we take actually the same grading system. We can see that residual, moderate, or severe mitral regurgitation post repair, by default means that the patient will go back to OR for either redo of the mitral valve repair or revision of the mitral valve repair, or sometimes mitral valve replacement. My biggest problem with my review of the great deal of the surgical literature, which is quite different from the cardiology literature, I have to say, that the value and the usefulness of the and the level of improvement in the quality of life or event-free survival after mitral valve repair, based on the presence or absence of this residual mitral regurgitation, was really very difficult, to get. To me, most of the studies that I came across, they have, they lump sum actually a group of patients. Sometimes, of course, some of them are degenerative. Sometimes, some of them are ischemic, and very, of course, a smaller number are rheumatic. And they put them together, and they did mitral valve repair technique for these, of course, for each series, and they got the results, and it is many times it's one center series showing actually one results for their work, and whether it's good or bad, I mean, you only have one surgeon showing actually what his results is for all these patients that he underwent repair. And I couldn't really have any way to compare it to anything else, because every surgeon has his unique patients, has his unique, I will say, surgical techniques, and of course, he will have a unique results. Whether these results can be reproducible by other surgeons in other centers, or whether actually we can compare it to other actually techniques, honestly, I wasn't able to answer this question. I think in my head, it's not yet clear enough. Most of the studies have a small number of patients, and this is at least, when we talk about, in the 80s, 90s, 70s, 80s, and 90s, once the mitral valve repair was introduced. And more importantly, there is no randomized studies. And it's very important, randomization. I cannot, tell you how to randomize patients who undergo mitral valve repair, of course, to control. But I can definitely say that there is a room for randomization in surgical studies, especially if you want to compare, like what Dr. Jamjoom, showed us before, and Dr. Richard Lee actually showed us this, like between mitral valve repair versus replacement, or mitral valve repair versus doing nothing. That will tell me actually a lot or a great deal of, of information. But since, and don't forget, I'm talking about here residual MR in adult patients. I have to, mention here that repairs results in pediatric population is quite different from repair in adult population. It's always important to put this in mind whenever we talk about, mitral valve repair and residual MR. This is a very nice example of, this is a patient with severe residual MR. The patient had repair. After repair, as you can see in the, in the left side panel, you can see there is still severe mitral regurgitation by transesophageal echo. The patient went back to OR. The patient had a very nice results after that. This is what I'm talking about. Patient had severe MR. He had it fixed. The first repair wasn't good enough. The patient went back to OR, and he had it fixed actually in the same, setting. Whether this residual MR is enough for this patient to have a good prognosis or not, we'll come into this in a few minutes.
5 minutes. Dr. Dajani, 5 minutes more.
Yeah. Residual MR, is it acceptable or bad? I mean, definitely residual MR is, is bad. But what's the meaning of bad here? It means that there are many problems with, I will say, the risk of reoperation, the risk of, the survival rate is going to be quite different when you have residual MR. I will show you actually, why residual MR sometimes is misleading when you do it in the operating room. This is a study that was done to measure the perioperative actually mitral regurgitation after mitral valve repair. Clearly, it's from this particular study, you can tell, just to for the sake of time, you can see that all mitral regurgitation was graded one grade up once the patient leaves the OR. So whatever the mitral regurgitation is in the OR, you have to expect that the mitral regurg will become worse after the patient is awake and before the patient actually leaves the hospital. And this is actually a study which was done on ischemic mitral regurgitation, and it tells you actually how, that the MR can become from very trivial actually at the time of discharge from the hospital to severe actually, within 5 years. Of course, in another study that actually is, if I have time, I will show it to you, that MR actually came back and become severe in ischemic functional within actually 2 years of surgery. So recurrent mitral regurgitation, of course, is known, and we have to admit that we don't really have, the perfect technique right now to fix this problem. I'll skip, of course, number of slides because this particular study, which was done also actually on ischemic MR, just to tell you, this is a very sick patients. We have very sick patients here who had really mitral valve repair. They have CABG, they have EF of less than 35%, but look at the recurrence rate. Look at the survival. Actually, within 5 years, 50% or about 50, I would say less than 60%, actually, they have, survival. They were alive after 5 years. And when you take the patients who left the OR with more than 2+ MR, when they left the OR with 2+ MR, look at the survival rate. It's only 35 or 36% versus 65% who left the OR with an MR that is less than 2+. So the amount of residual MR is definitely important in deciding what will happen to this patient in particular. I don't want to, since I don't have too much time, I want to say here that there are, we have a huge follow-up actually for patients with mitral repair. We have 20 years follow-up that was done in Duke, and we have actually 4 decades of experience post-mitral valve repair. All of them, of course, agree on one thing. The best results of patients after mitral valve repair are seen in degenerative myxomatous mitral valve. The results in ischemic mitral regurgitation when it comes to residual MR and what will happen to them actually within 2 years to 5 years does not look very good. In one study, actually, the mortality rate within 2 years of surgery for mitral valve repair after, in ischemic MR was 50%. This is really very dismal results. And I have to say that, maybe we have to do better in different aspects of repair, not only from the surgery side, but also for the cardiologist who will, who should actually put or give more information about the mitral valve pathology, where the pathology is, and how to improve the technique and how to improve the results, post mitral valve repair. I will go back actually. I just want to show some. If you give me just 1 minute, please. Surgical mitral valve repair remains the best surgical approach compared to mitral valve repair. There's no question about this. But the role of repair, in functional ischemic MR is still not conclusive. I believe that in our clinical practice, mitral valve replacement maybe has better success rates and freedom from reoperation when it comes to ischemic MR. I know this statement probably is controversial, but I would rather to have a patient with competent, prosthetic mitral valve than to have a patient with a failed repair. I'm talking about here in an extreme, term. Surgical mitral valve should be considered, and it is the operation of choice for many patients with mitral valve. But in our part of the world, and that's important, to say, the mitral valve repair has not yet been a feasible choice in many regions of this country. So when we talk about mitral valve repair, you have to put in mind that this is only available in certain centers across, the kingdom, and we have to always to think about it in that perspective. All the centers with high volume of patients and with cardiac surgeons that who feel comfortable in doing mitral valve repair, and they have, a decent actually echo department who has actually excellent echocardiographers who can help them to identify the pathology and the repair, and the result of repair should be allowed to do these, surgeries. Mitral valve repair is successful. The majority of patients, of course, should leave the operating room with no mitral reserve. This is the definition of successful mitral valve repair: no residual MR. Whenever you have residual MR, you have to worry and you have to close these patients very closely. Residual mitral regurgitation can be tolerated if it's less than mild. I would not say 2+, if it's less than mild. In the literature, 0 or trivial. Mild or even more than mild is considered to be a bad outcome after mitral valve repair. Post-repair and outside the operating room, we have to remember the severity of mitral regurgitation usually is 1 grade up. So always put this in head because we know that the patient just came out of surgery or he's just recovering from the, he's still actually recovering from the bypass, the anesthesia is there, and the loading conditions are different. So that's why, put, extreme caution when you assess these valves. Mitral valve repair failure is considered when the 2D echo done for the awake patient prior to discharge from the hospital shows more than trivial mitral regurg. Just in my definition, this is the last slide. Mitral valve repair studies should be reported on an intention to treat, and this is a major default, a major fault in the studies that, I think in the surgical literature about all the results. The mitral valve repair studies should be done on intention to treat basis as the study of the raw numbers, like patients who did not complete the repair or patients who had bad results had to go back for redo repair or mitral valve replacement who are normally excluded from these studies. Once they are included, when they follow the intention to treat basis, I think we'll have much more understanding of mitral valve repair and how good we are, in doing such procedure. Thank you very much.